Like, how much stuff is there this week? Like, I don't feel like this week is that heavy. Am I right in saying that?
I think it was all right. I remember the week before mid-sem break was like deceivingly chill, and then it's like you have to do a lot of stuff in mid-sem break, something like that.
And it should be like fairly quick, I think. Right. I think the longest bit is like Outbreak Investigation.
Yeah, that's just read it by yourself. Like the lecture, I don't remember much of.
I remember they got someone
A
from
lot of
like from
words.
the DHHS or something.
Yeah, they were like some infectious disease person
Yeah.
that was like, yeah. And I remember, was it? No, it wasn't them. That was Penny. Penny was the one who told us about the river analogy.
River.
The one where it's like
Oh,
you can save the kids one by one, but like
yeah.
eventually you're going to get tired, or you can find out why the kids are like falling into the river and drowning. But like that
Yeah.
was Penny. No, this infectious. I remember they also told us a story about why
I was not
pop
paying
health.
attention.
I wasn't either. I'm surprised I have notes on it, but I have notes on all the lectures apparently because
Wow. That's great. That's good. That's good.
I wasn't actively paying attention though because I still needed to, cram the night before.
Who are we waiting for? 9 people in the Kahoot. I'll like start it at 3:40. Just
Everyone
so I
just
can.
like breathe.
Yeah.
Mid-sem break is
Love
coming
mid-sem
soon.
break. Okay. Genuinely, these 4 weeks, like, oh wait, like, so good. Did Zoe say what time she'll get here? No. Cool. So this question, we have 2 enzymes, COX-1 and COX-2. Stands for cyclooxygenase. Number 1 is normal functioning. So I guess the one that we're mostly concerned about is like maintaining the stomach's kind of mucous membrane, whereas COX-2 is all about inflammation, which is why we prefer to inhibit COX-2 so we can reduce inflammation and reduce pain. The adverse effects of inhibiting COX comes from inhibiting COX-1, which inhibits the normal functioning. And that's why you get like your gastric disturbances or like your ulcers. Yeah, and then red is just the wrong way around. So at low doses, well, the dosing matters for aspirin because at different doses you get different effects. So at low doses, you typically get like your antiplatelet activity. So it helps to like essentially thin your blood. So therefore it kind of helps with your cardiovascular things, which we'll probably touch on a bit later this year. Yellow is the opposite of what we want, so we don't want to make it more difficult for our heart to function. And then generally, and then we'll do the next question because I nearly ruined it. Good. Yeah, so at high doses, it's more of an antipyretic, so kind of gets rid of your fever. whereas your low doses is your blue and your yellow options. Red is kind of the opposite of what we'd expect with the NSAID, since you're inhibiting that COX-1 enzyme. So paracetamol is more centrally acting, more in the central nervous system, so it doesn't really have an effect in terms of inflammation. Yeah. So it's all limited kind of within the central nervous system, which is the reason why it's not anti-inflammatory. Good. So oral corticosteroids is kind of talking about the kind of the adverse effects that you get from corticosteroids, or just like your steroids, which is immune system suppression. And that especially happens if you're at like relatively higher doses for longer periods of time. It isn't asthma because we actually give oral corticosteroids for asthma because it kind of helps open things up a bit, helps them to breathe a bit easier. Whooping cough isn't really an effect of corticosteroids. It's more of a pathogen that causes the whooping cough. Your pertussis, I think. Your mild sore throat is just not quite it, because we're really just focusing on the overgrowth of bacteria, which results in your oral thrush, which is also why, like for asthmatics who take orally like inhaled corticosteroids, that's why they rinse their mouth afterwards, to kind of avoid this oral thrush. Good. Yep, that's an important definition. It's also an exam question, which I realized when I was looking through them. So pain fibers, remembering like it's a bit of revision on the dorsal horn and the ventral horn, remembering that your dorsal horn is all sensory. So it'll synapse at either at the dorsal root ganglion or the DRG, and that's all sensory function. Whereas your motor function will exit through the ventral horn. Yeah. So yeah, the descending pathway is in modulation, so it's kind of controlling the amount of pain we have. So it's anti-nociception or anti-pain. And this is the system we kind of exploit when we deal with opioids, which are things like, they're very, very strong, like your morphine. Yeah, like your morphine. So it'll actually increase this descending pathway in order to decrease the amount of pain by a whole lot. So the descending pathway doesn't have anything to do with your sympathetics. It's concerned with different nerve fibers. And then pro-nociception is opposite. It's all about modulation and reducing the amount of pain. The withdrawal reflex is the act of withdrawing, say, your hand from a hot pan is a motor function. So it might come as a result of pain being sensed in your hand, but it's not involved in pain modulation directly. Yeah, so warm receptors only have tonic firing, whereas cold receptors have both. Yeah, that's kind of a feature of warm and cold receptors. Yeah. So local anesthetics, they're essentially kind of stopping your nerve from working. So we're going to be stopping the sodium channels because those are really important for propagating the action potential. So it's a very, very slight difference whether it binds onto the intracellular region or the extracellular, and it's the intracellular region that it binds to. And therefore it blocks the voltage-gated sodium channel and therefore stops your pain signals from passing to the nerves, which is why, oh, not even just pain, like just every sensation. And that's why it's an anesthetic. So yeah, that's perfect. So we don't want adrenaline to spread all throughout the body because we want to reduce the systematic toxic effects. Like we don't want to be blocking nerves where we don't want to be blocking them. So therefore we try to restrict it to a certain area, and that's through adrenaline. So to vasoconstrict the vessels around the area and therefore to stop it from moving around. Yeah, I guess green is a bit of a tricky one, but the reason why it's not correct is because adrenaline isn't directly reducing the pain. It kind of just helps to accentuate the effect of the local anesthetic in that area. So it's not directly involved in it. Good. So a p-value of less than 0.05 is essentially saying that like the effects that we've seen here are probably not due to chance. There's probably a systematic effect occurring here. So therefore, we accept the alternative hypothesis that states that there is a relationship between the IV and DV, and we reject the null hypothesis that states that there isn't a relationship between the IV and the DV. So therefore, we reject it. So your patella or your kneecap kind of articulates with your femoral condyles. And it's true that both of them kind of help to restrict the movement because they kind of provide these bumps that stop them from moving from side to side. However, it is the lateral femoral condyle that stops the movement more. And that's primarily due to, I believe, like the muscles that it's like a net pulling to the lateral side. So therefore, your lateral femoral condyle needs to stop it a bit more. And that also gives a reason why your vastus lateralis doesn't stop patellar movement. In some ways, it kind of increases the movement. So if you look on the slides, there's something called the Q angle. And the Q angle will talk about the vastus lateralis because it will kind of pull the patella off its proper position, which increases the risk of its abnormal positioning. So that's a fact to know. The lateral femoral condyle helps to avoid movement. Also a past exam question. So we have 4 bursas or bursae around the knee. The suprapatellar, which is kind of above your kneecap, your prepatellar, which is right in front of your kneecap, your infrapatellar, which is below your kneecap, and then the semimembranosus, which is next to the semimembranosus muscle, kind of in the popliteal fossa. So it's called a clergyman's knee because I guess a clergyman would kneel down, and when you kneel down, you kind of the main point of contact is between like the lower part of your knee or the bit below your patella and the ground, and therefore, if you have a lot of contact there and a lot of moving and a lot of rubbing, you're going to get inflammation of this infrapatellar bursa. Yeah. Okay, so the key word in this question here is a pulsatile lump. And the reason why this gives a really large hint between a Baker's cyst and a popliteal aneurysm is because you have to remember that an aneurysm kind of refers to this swelling or this bulging of an artery. And with all arteries, you can always feel the pulse. So if you feel a pulsatile lump in the popliteal fossa, there's a good chance that it will actually be an aneurysm. Whereas a Baker's cyst, it's also a lump in the popliteal fossa, it just probably won't be pulsatile. Deep vein thrombosis will come up a tiny bit differently. Veins are also not pulsatile. And you mostly just get pain kind of with the DVT. Compartment syndrome is like this overall swelling of the compartments that are enclosed by really tough fascia layers. So it won't just be limited to like a pulsatile small lump. It'll be more of a widespread swelling in say the thigh region, and that's a pretty large emergency. So really common injury an ACL tear. And the function of that ACL is to stop that forward slipping. So if you tear it, you're going to get excessive forward slipping. And you'll learn it, I think you're learning it this week or next week, I think. But you'll have a test for this where you essentially try to pull the tibia off the person. And that's called the drawer test. Yeah, it's a bit of a scary one. Yeah, posterior cruciate ligament is opposite. So it'll try to prevent backward slipping of the tibia off. Yeah, it'll prevent backward slipping. And then your lateral and collateral, your lateral ligaments. Yeah, your lateral ligaments, that'll kind of prevent sideways movement. Yep, good. So vibration, you generally start distal and then work more proximally. Even though, like in your exams, you don't really have to test multiple locations. So we don't want to do options blue and green because that will cause the vibration to essentially stop. You want to put like the single end of the Y onto the patient and hold it by the junction. 512 is just the wrong frequency. I think it's 256 that you use. That was also an exam question. Yeah, good. So the lateral ankle ligaments are most commonly affected. And that's because the range of motion for inversion, for ankle inversion, is greater than eversion. So therefore, if it's greater, you're at a greater risk of kind of going too far and injuring these ankle ligaments. Medial ones can still be affected. It's less likely. Yeah, good. Cool. So good job to everyone. It was a bit more of a clinical test, I guess, for lower limb. And yeah, we'll make this public. So shoot us any questions you have, and we'll do our best to answer them. Otherwise, we'll start on content. I don't know who's starting, but
MSK Infections is first. Should we just start with that? Yeah, we'll just start with that. We'll start with that. All right. Okay, so I think this week it's skin and MSK infections, and I think this was given by like an external lecturer who goes into a lot of detail because I think they were obviously very passionate about their own field of study. But worry not, you probably do not need to know as much detail about each of the infections as the lecturer enthusiastically goes through. All right, so first going through a few different symptoms that you might see on a skin infection, and I've essentially organized it all into a table. So we'll just go through them. A macule, this is normally a flat circumscribed discoloration of the skin, and it's normally pretty small, so less than 1 centimeter. A papule is a solid circumcised and elevated lesion, and once again, pretty small, less than 1 centimeter in diameter. A pustule, I think most people probably know this one. So it's essentially like a papule, except there's pus in it, so it's purulent. The word purulent just means there's white pus in it. A nodule is essentially like a solid lesion. It could be elevated or it could be flat. And it's normally more than 1 centimeter in diameter. You can get something called vesicles. So these are small circumscribed lesions that are normally elevated because they contain serous fluid, and they're typically very small. Bullae are essentially just the larger version of a vesicle because they're normally larger than 0.5 centimeters in diameter, and once again, they also contain serous fluid. Petechiae is essentially something that looks like this. So you've got really small, erythematous just means red, so very small little red dots almost. They are non-blanching. That just means that if you were to press down on it, they don't turn white, so they stay red even when you press down on it. And it's normally due to capillary hemorrhage, so damage to your tiny blood vessels. Purpura is essentially just purple discoloration of the skin. And once again, it's non-blanching, so just because you press down on it doesn't mean it's going to change color, it's going to stay purple. Something called a plague is essentially a circumscribed solid lesion, normally elevated, normally larger than a centimeter in diameter, and normally it's described as like a plateau with a flat top. Something called a wheal, they're transient elevated papules, and they normally have essentially like a red border, so that should be border. So a red border and a pale center. So let's actually move on to the types of skin infections, which are caused by, let's start with bacteria. So one is cellulitis, and this can be caused by a bacteria such as your Staph aureus or your Pathogens, and it normally involves a subcutaneous tissue. And the features is a unilateral red, swollen, shiny leg, normally accompanied with a fever because it's an infection. So those are like buzzwords for cellulitis. TSS, so toxic shock syndrome, caused by Staph aureus, can also manifest with some skin symptoms, but just note that obviously if that does happen, really the telltale signs of a TSS isn't going to be desquamation of the skin, it's going to be the other more systemic effects due to your multi-organ failure. We have something called scalded skin syndrome, which once again is caused, which can be caused by Staph aureus. You'll soon notice a pattern. Its features include large areas of skin desquamation. Desquamation just means that we are essentially killing off the skin cells, which can also therefore result in blisters. And it's called scalded skin syndrome because it kind of, the area of infection kind of looks like scalded skin that's just been burnt with like hot water, hence the name. So another type of skin infection is necrotizing fasciitis, which is caused by S. pyogenes. This is a pretty severe infection that can not only affect the skin, but it can kind of go down into your deeper layers, such as your fascia and your soft tissue. And because it is more severe, you'll get more severe symptoms such as purple skin necrosis, as well as more intense pain. Another one is gas gangrene. And it can be caused by a bacteria called Clostridium perfringens. And this one is, I think, more common in terms of what appears on your exams. If someone has this, you have to go into a meat surgery and treat with, antibiotics straight away. Normally it results in limb amputation because the tissue or the area that is being affected or that's being killed off or necrotized is so fast spreading that really you don't have enough time to treat it with antibiotics. You kind of just got to realize, okay, this is the area that's been affected. I've now got to essentially cut off the limb high enough just to make sure that, the rest of the body doesn't get infected. So it's a pretty rapid onset. You get a lot of like discoloration. A buzzword for gas gangrene is crepitus because gas gangrene is a type of or Clostridium perfringens is a type of bacteria that produces air. So crepitus just means when you move their limb, you kind of hear this crackling sound almost, and that's because there's like air trapped inside. And you can also get these blisters that form here. Leprosy, I think it's one that some may have heard of before. It's caused by Mycobacterium leprae, which is an obligate intracellular organism. It's more of a slow progressive disease. So you can have two types of leprosy. There's one called tuberculoid leprosy, and another one is called lepromatous leprosy. So for tuberculoid leprosy, our body is essentially capable of actually mounting some sort of response to the infection, and its symptoms include a blotchy and red face. Whereas for lepromatous leprosy, our body is essentially incapable of mounting a response to the infection. And it is typically characterized by something called lion face. So someone's face looks like a lion. This just includes swelling of the cheek and overgrowth of the forehead. Another skin infection is syphilis, which is caused by Treponema pallidum. And normally this is just painless ulcers, maybe a rash, but a lot of the times can also be asymptomatic. So moving on to our viral skin infections, or we can have the infamous chickenpox, which I think a lot of people know, which is caused by VZV, which is a varicella zoster virus, which is a double-stranded DNA virus. It can be transmitted via respiratory droplets. You treat it with antibiotics such as acyclovir. And once someone has chickenpox and they're essentially their immune system overcomes it, the virus actually lies latent in your body, so it kind of goes into hibernation almost. And if the person becomes immunocompromised or if they're extremely stressed, then essentially this sleeping virus can awake and it reactivates again. However, nowadays, we do have a live attenuated vaccine for the varicella zoster virus. Another one is the herpes simplex virus. It can also cause some skin problems. So we have herpes 1, which causes our cold sores, generally transmitted by saliva. So if you're kissing someone, for example, we have our herpes 2, this one which generally causes more of your genital blisters or ulcers, and it's normally transmitted by sexual contact. And once again, the treatment is acyclovir, which is not an antibiotic, I'm sorry, it's an antiviral. What am I saying? Another one is called slapped cheek. It's caused by the parvovirus, and pretty much you just have red rashes on your cheeks as well as a fever, hence the name slapped cheek. Okay, moving on to our fungal skin infections. The main ones to know include Candida, which is also the fungus that causes things like thrush. And you would treat this with antifungals such as fluconazole. Another fungi is tinea. Another condition is tinea, and this is a superficial mycosis. That just means that the infection essentially stays on the very, very surface of your skin. And the features of this include an itchy, red, scaly rash, rash-shaped blisters, might get some sweating and bald spots on the scalp. Another fungal skin infection is dermatophytosis, which is caused by dermatophytes. And these are essentially cutaneous mycosis. So that just means that they're still on the skin, but unlike superficial, cutaneous just means it can essentially go into the more deeper layers of your epidermis. And the reasons why dermatophytes cause a cutaneous mycosis that only maybe grow on your skin, for example, is because they require keratin to grow. So they wouldn't be able to invade your deeper organs because your deeper organs just aren't abundant in keratin. And the features of this include a red, itchy skin rash. Just a little bit on bone and joint infections. We went through in the lecture, but I really don't think it was that important. So one is osteomyelitis. So this is an infection of the bone, and it most commonly occurs in the ends of our long bones. Once again, what pathogen can cause it? It can be caused by Staph aureus. And essentially, you get something called sequestrum, which is hard devitalized bones. This can form and it needs to be surgically removed. You can get osteomyelitis through like an open fracture or a transferred infection from essentially other surrounding tissue. You can get septic arthritis, which is red, swollen joints accompanied with a fever, and typically your prosthetics will be the source of infection. Okay, and I think that's all. Really, I don't think this lecture is that high yield, but if I had to go through the more high yield versus low yield areas, it would just be your skin infection symptoms. Probably at most, I would say, sorry, at most would be maybe one multiple choice question. So if you want to memorize them, go ahead, but I don't think they're that important. Anyone else want to confirm?
Yeah, no, yeah. I don't
Yeah,
know this.
exactly. Yeah, don't worry
The
about it.
important one is like maybe petechiae when you do like cardio later.
Yeah, maybe petechiae, but
Yeah.
other than that, really, like, don't worry about the size. At most, one multiple choice question. All right. In terms of which infections, probably for bacterial, I would say cellulitis, necrotizing fasciitis, and gas gangrene are probably the three most high yield ones. The other ones, not too much. For viral,
Syphilis will come up again in like second year, but yeah.
Not important now. Yeah.
Yeah.
And viral would be your chickenpox and your herpes. Make sure you know the difference between 1 and 2. And fungal, probably candida. Yeah. That's pretty much all the relatively more high yield stuff this section. Cool.
Yeah, good. What else do we have? Viral pathogens.
Yeah, okay. I'll share my screen.
Yeah. Cool.
Right. So for viral pathogens, it's also quite straightforward. There's not much to learn. So you just need to know a few key things. So for key features of your virions, your viruses, is that they're acellular. They obligate intracellular parasites, which means they need a host in order for them to replicate, and they cannot survive by themselves. And yeah, so the main structures that you need to know is that they can have either DNA or RNA, and they may have an outer lipid envelope or they may not have. Yeah. So there's a few key stages of transmission and multiplication that you need to know. So viruses have to attach the host cell. So that's the attachment phase. And different viruses bind to different cells of your body. So in particular, like influenza binds to your respiratory epithelia and so on, but you don't need to know that in detail. So you just need to know the few stages: attachment followed by penetration, where the virus is uncoated, enters into the cytoplasm, replication, where your RNA is synthesized, and then assembly, where new virions are synthesized and released, where there's a cell lysis and there's budding of your virions into the host environment. So because of this, there's quite a few outcomes of a viral infection. So most severe would be oncogenesis, where normal cells can transform into tumor cells, and this is because there's activation of oncogenes when the RNA of your viral sequence is added into your normal human DNA. There's also cytopathy, which is where your tissue is damaged, and immunopathology, where you can get inflammation caused by immune cell infiltration due to a site of when a site is infected by a virus. And this could also lead to autoimmunity, where there's an immune response to your own self-antigens. Or it could even be asymptomatic, so there's no harm at all, where the virus is just latent and the genome is just integrated into the host cell and it's not active, so it just stays dormant. So there's quite a few outcomes that a virus could cause, but you don't need to know exactly what each virus does. There's specific viruses that we'll be going through that you need to know. So you need to know how to classify certain viruses. So classification can be done in a few ways. DNA, RNA, that's by the nucleic acid. Could be whether there's absence or presence of an envelope, the shape and symmetry of the capsid. And there's this particular classification of the Baltimore classification, where the positive means that the mRNA of a virion can be immediately read and processed, whereas the negative would mean an mRNA can't be synthesized directly. It has to be converted into a readable form before they're transcribed. Okay, so the classification that you'll be learning in year 1 is by the different nucleic acids. So there's a few viruses that you need to know for each different type. So for DNA virus, you need to know HSV as well as human papillomavirus, HPV. So HSV is basically it's a DNA virus, and there's 2 types of HSV. There's HSV1, which is your oral herpes, and HSV2, which is your genital herpes. And basically, these viruses they establish latency in your ganglia, and they can be reactivated in your lifetime again due to different factors, be it stress or other factors. Yeah, so the invasion mechanisms basically is that it degrades the host mRNA. It basically inactivates the C3b complement protein, so there's no inflammation, and just avoids antibodies. And for HPV, again, it's a DNA virus that you need to know, and it can cause either skin or genital warts. And yeah, so since it interferes with your RB and P53, so these are your cell cycle checkpoint markers, right? So when they disrupt these tumor suppressor proteins, they actually can cause various cancers. And in particular, it increases the risk of cervical cancer. Okay, so that's for DNA viruses. So now for double-stranded RNA viruses, the one you need to know is Hep C. So it's a double-stranded RNA virus, and it can be spread through, it's a blood-borne virus, so it can be spread through IV drugs, tattoos, invasive procedures, and basically it affects the hepatocytes. So, and it causes an inflammatory response, causing your liver to be damaged. So it could lead to fibrosis and cirrhosis of the liver. And yeah, so because it continuously, spontaneously mutates, you can avoid your immune system. So that's for double-stranded RNA. And for single-stranded RNA, you need to know HIV. So it's a retrovirus. Retrovirus means that its RNA is converted to DNA initially. And it's transmitted through blood, semen, secretions. And how HIV avoids your immune system is that it binds and lyses your CD4 T cells. And when it does that, basically it results in immunosuppression of the individual. Yeah, so talking about retroviruses, how it works is that your RNA is injected into the cell, and then DNA is reverse transcribed and then integrated into the cell's genome. And then the cell actually produce proteins and the virions, and latency is established. Another single-strand RNA virus that you need to know is influenza. So that's basically your infection of your upper respiratory tract and lower respiratory tract. And sorry. Yeah, H is before N, yeah. So H is entry, N is for release. And it undergoes 2 different mutations. So we've got antigenic shift and drift. So drift is point mutation. So the single strain can have different variations. And shift is like a combination of different strains. So it changes from like year to year. That's why you have to keep on getting vaccinated every year for influenza. Yeah, and then another single strand is Ebola. So yeah, it's a zoonotic virus transmitted through bats, and yeah, it's spread through bodily fluids, and it can cause pro-inflammatory cytokine release. Yeah, so that's basically it that you need to know for your different viruses. So you just need to know that your different viruses can result in quite a few outcomes. So you've seen HPV, HSV can be latent, and then Ebola can result in an immediate immune response, and some can result in your cells transforming into tumor cells. Yeah, and you just need to know these specific viruses in general and how they're categorized into DNA and RNA. Yeah.
Nice. Zoe's not here yet, is she? Yeah.
I think Zoe said she'll be here at the very end. If not,
Okay.
we might need to just cover her slides, but it's just psych.
Yeah, it's just
Zoe's
like.
doing.
Do you want to go through outbreak investigation?
I'll go through it briefly, guys, but it's I have uploaded my lecture notes that basically go through everything in detail, and there's a few case studies as well that were mentioned in the lectures, but I didn't put in the slides because honestly, like, the slides are long enough. But yeah, I'll just briefly go through it, but most of the content is in the slides or in the notes that you can have a look at in your own time. I personally don't think this was actually on the end of year exam. Like, I genuinely don't even like remember it being assessed. Even in our pop health quizzes, like, I don't even remember it being there. So this is just, I think, like, cool general knowledge. That's like,
I think there was only one bit that was like kind of examinable, and it was just like latent period, infectious period, incubation, and symptomatic.
oh yeah, like natural history of disease, but that's like not really pop health. Like, that's kind of other. That's like,
I think that's the only thing that was tested.
yeah. Okay, so outbreak investigation, like, wow, so relevant to the current climate, which is cool. So just some definitions. So an epidemic is when there are more cases than expected of a particular disease among a specific group of people in a given area over a particular period of time. And what is considered more cases than expected we'll go through in the rest of the steps. But there's a way that they calculate, like, they'll, like, through surveillance, through all sorts of things, about whether we consider something an epidemic, so more cases than expected. So outbreak is basically the same as an epidemic. I think people, you can usually use the words like interchangeably. It may be a smaller number of cases or an area or a population. Epidemic just obviously like sounds fancier. Pandemic is worldwide epidemic, which is what we are currently in. So a cluster is a group or an aggregation of cases, and endemic is when there is a permanent or regular disease incidence. So it's like always there. Natural disease history. So this is what Peter was mentioning about, like, the kind of the only important bit that gets gone through in the lecture. So you kind of just need to know the natural history of disease, like how the different periods that occur during disease. I'm pretty sure this was actually gone through in a different lecture, and it's only like mentioned in this, but this is just cool to know. And
yeah, it's just like there's like the main important thing to know is like the really dangerous period is like when it's infectious, but it's not symptomatic.
Yeah.
Like that middle bit.
It's like this bit.
Yeah, that bit. Yeah, that's the dangerous bit.
Yeah. So once again, there are lots of case studies that get mentioned. I think they mention Ebola, they mention HIV, and they mention like measles as well. I'm pretty sure they're going to mention corona for this year's lecture. If not, if it's just a recording of our previous lecture, then unfortunately they won't go into it. But like, if it's a live lecture, they'll probably go into it. But yeah, please see the extra notes if you want to look at the case studies. There's not like specific, like, important information you guys need to take away from that. It's just cool facts about previous either pandemics, epidemics that have happened, and what we learnt from that. So a couple of reasons why outbreaks will occur. So there's three. There's either a new appearance of an infectious agent from the environment or from an infected source. You either have an arrival of susceptible people to an environment with an endemic pathogen, and that has naturally occurred with the increase in global travel. So like one of the reasons why coronavirus got like so big so fast was because we're living in an age where global travel is very easy, very accessible, and it's very easy for people to travel from an infected area into an area where the pathogen wasn't exposed to before, and then, you know, we can very easily turn it into a pandemic. And lastly, introduction of effective route of transmission from source to susceptibles. So an example of that is climate change bringing new mosquito species, and then there's a whole issue with like malaria, and then there's a whole issue with kind of pathogens that are carried through mosquitoes. That's a whole thing. So the reasons for outbreak investigations. So the reasons why we should actually be doing population health and epidemiology and actually studying this. So we need to do outbreak investigation to result in timely public health action and intervention. So we can identify both the pathogen or the source and then control it, which is stopping the new cases. Otherwise it's just going to get worse and worse, and then it's going to become out of control. And then after we do that, we can prevent future outbreaks. So it's all about identifying, controlling, and then ultimately our goal is to prevent. You also get the opportunity to learn more about like a new disease that you might not have known about before. And they mentioned it's a training opportunity as well, which is like, okay. So all these decisions about when to do things, what they're going to do is based on case numbers, the disease severity, whether it's going to be a risk to others. There's a lot of public health, political, legal concerns that go into it. So there are 10 steps to outbreak investigation. And as you can see, there's a lot of slides for this. So we'll just go through them very briefly. So step one is prepare for field work. So before you go out into the field, right, you need to prepare before you actually step out onto the field. And so these are all the things that you do to prepare for field work. So you need to do your homework about like epidemiology. So what are the risk factors? Are there previous outbreaks that we can like gather information from? What do we already know? Gather your supplies and your equipment, gather your team, have like administration. So like figure out your transport, communication, figure out all this nice stuff. And so step one is just prepare. You're preparing to go out into the field to investigate. Step two is you need to verify the existence of an outbreak. So you need to, so it's defined as more cases than usual, right? So what is the usual kind of standard? So you must specify both community or region and the time period, and you must have methods in place to record actual usual or baseline patterns of disease. So that comes through surveillance, so actually monitoring the disease in the populations. And there are different types of surveillance that we have these days. So there's this wonderful table. So there were traditional forms of surveillance. So you can look through that yourself. And there's like innovative, which is what we're kind of using now. Which is a lot of reliance on like technology, new technologies, like labs, press, media, different organizations that will actually help you with surveillance and kind of monitoring that baseline. Yeah, there's more to step two, verifying the existence of outbreak. You guys can look at that yourself. There's a lot of words in this lecture. And a lot of it, I think, is actually very self-explanatory, but it's also just cool to just kind of like read through it, kind of get a basic idea, basic overview of what goes into like actually investigating. Step three, confirm the diagnosis. So you're going to have to review your clinical findings, review lab results. You want to be as specific as possible about the causative agent So you may need like a specialized lab for that. Talk to the cases, so actually talk to the people who have been infected. And these are some good reference labs that they mentioned in the lecture. Yeah, cool. Step 4, you need to define and identify your cases, because case definition is very important and it can actually change over time. So these are some of the components: your clinical features, the person, place, time period of interest, the lab results, and then you divide them into these 3 categories. So confirmed, usually that's through a lab. Probable, which is where the lab results aren't available yet, and possible. And then this is just a case example of Hep A and how they actually went about doing this particular step. Okay, step 5, describe and orient your data in terms of person, place, and time. This is in the notes for more details. There's lots of different ways of graphing. Once again, wasn't very useful. A lot of this lecture you'll find wasn't very useful, but it's just cool, interesting stuff to know. But yeah, so there's lots of different ways that we actually graph this information, just, visually. And then step 6, 7, and 8 is all relevant to hypotheses. So 6 is develop a hypothesis. 7 is evaluate your hypothesis. And then 8 is refine your hypothesis and perform some additional studies. So you have to figure out what is the source of the infection, whether you want to do a case control, whether you want to do a cohort study. These are some factors to consider for case control. They didn't go into any factors regarding cohort studies, so yeah. But yeah, basically step 6, 7, and 8 are just kind of like a lump group where you just formulate a hypothesis. Step 9, so you need to implement control and prevention measures, because once you have identified the source of an outbreak, you want to break the links in the chain of infection. You want to stop it and prevent future infection as fast as possible. So some examples could be removing the contaminated food, sterilizing contaminated water, getting rid of the mosquitoes, destroying breeding sites, etc., etc. So you want to break the chain of infection as fast as possible once you have identified. And then step 10, last step, is just communicating your findings. So basically, usually it's in a final written report, plus or minus any extra additional publications. You want to clearly state your facts, manage any public outrage, which is very rampant right now. Beware of any legal, ethical implications, and basically the overall aim is to improve practice for the future. So you want to communicate your findings so you can prevent this from happening in the future. And that's basically it. Steps for outbreak investigation.
There was a question are there any questions on this in the exam?
No, I genuinely don't remember it coming up in the exam. I looked through my notes and I was like, this was a thing. We actually did this. Wow. I think the only thing was the one that we mentioned at the start. The most dangerous period is when they are infectious, but not yet symptomatic, because they're probably going around in the community spewing disease, but they don't know it yet. And that's kind of just the most dangerous thing. So yeah, that's kind of the main important takeaway. The rest of steps to outbreak investigation, no, they're not going to ask you what is step 5 of outbreak investigation and blah blah. No,
Won't happen. There's still the HLSD stuff, but I don't know. I think Zoe's still tutoring or in her meeting. So
what is HLSD?
It's adult development, which is friendship, marriage, violence, aggression, and career choice, and occupation and leisure. I remember doing this. Like, I remember watching it. I didn't go to the lecture. Like, I was watching it afterwards, and it was, I think, like, fairly self-explanatory.
I don't remember this. I think this probably was a lecture where it was just like copy it from the slides.
Yeah, it was copied
it's
from
very
the
much
slides.
explained on the slides.
Clinical exam questions are like, I put one in the Kahoot. It was the one about vibration. That was a real question. Otherwise, they'll ask like, this person is unable to abduct their arm against gravity. What is their power rating?
It's very much linked with anatomy in the end of your exams. So, yeah. I'm trying to remember an example.
Otherwise, they'll ask you about like heart, like things that you haven't done. Like a lot of it's to do with like the heart, I think. Like where
a lot of cardio questions.
Yeah, like where's the like the apex beat?
Special tests. Ooh, I think there might have been. There might have been like that. Someone will come in with a particular presentation, and they'll ask, so what extra special tests or what extra normal tests would you conduct on this patient to kind of get closer to a diagnosis? Like the presentation will be pretty specific already, and then the special test or the extra test will be to basically confirm your diagnosis. So yeah, it'll be a pretty specific kind of question. But yeah, there's not like they'll like list, oh, what is like the Thomas test? Like they don't ask them. It's very
they'll
much
ask they'll ask like in like with someone with like a issue with their supraspinatus, like what test might you do? And you might say, I don't know, like painful arc test or something like that.
Was it like that one where it's like above like 60 to 120 degrees is like
yeah, it's just that.
How did you guys do HLSD?